body is made of trillions of cells, and to cooperate as organs, cells have to interconnect with each other. This is achieved by adhesion molecules such as ecadherins that work like a zipper, sticking cells together. However, mutations in the CDH1 or CTNNA1 genes can lead to faulty instructions to build these molecules, allowing cells to move more freely. This causes a syndrome called hereditary diffuse gastric cancer, which is characterized by a loss of cell adhesion. So what is this syndrome, and what should we know about it? It's not that complicated. It's simply rare. Hereditary diffuse gastric cancer, HDGC for short, is mostly silent, and mutation carriers have around 50% chance of developing diffuse gastric cancer, and as early as in the second decade of life. Female carriers are also at a higher risk of developing lobular breast cancer, usually in the fourth decade of life. So clinicians suspect of HDGC when they encounter families with diffuse gastric cancer in young people, or in combination with other cases of gastric cancer or lobular breast cancer, or with cleft lip or palate, or in the case of Maori ancestry. Lobular breast cancer alone can also raise concerns of HDGC when there's more than one case at an early age. Suspected individuals are offered a genetic test. Confirmed carriers of the mutation can opt for an intense surveillance plan or may choose to undergo risk-reducing surgery for both stomach and breast. Female carriers are offered yearly breast MRIs, starting at the age of 30, with optional yearly mammograms from the age of 35, which makes up for a rather effective surveillance plan. Still, many carriers choose to eliminate any chance of breast cancer by performing a bilateral risk-reducing mastectomy, followed by breast reconstruction. Carriers are also offered a surveillance plan for the stomach, comprised of yearly endoscopies with multiple biopsies covering the different regions of the stomach wall. But in this case, endoscopy is not an effective tool to the timely detection of diffuse gastric cancer, as the cancerous cells spread insidiously through the stomach wall. Carriers are advised to remove the stomach as a prophylactic measure. You might be wondering, how is it possible to live without a stomach? Well, not only is it possible, but you can live a normal life without it. After surgery, an adaptation period of around 2 months requires rigorous diet restrictions of liquid or softer foods and in small amounts. But afterwards, carriers can follow a regular diet, just like any other person. Still, the absence of a stomach leads to vitamin B12 deficiency. That has to be supplemented on a regular basis. And some medications may not work as effectively due to the lack of gastric acid in the digestive process. Alcohol should also be avoided, as it is rapidly absorbed by the organism and might lead to, well, unwelcomed consequences. As much of a nuisance as it is, the removal of the stomach saves lives as it eliminates the risk of gastric cancer. Carriers have a 50% chance of passing the faulty gene to their offspring, but fortunately, medicine can offer pre-implantation genetic diagnosis, allowing the transfer of embryos without the mutation, effectively putting an end to this syndrome in coming generations. There is much to offer to families affected by HDGC. Prophylactic measures greatly reduce the risk of cancer and allow carriers to celebrate life, surrounded by family and friends. Just be careful with the bottle, will you?